Hello, and a very good afternoon to all our viewers. Welcome to this brand new session of Dent Essentials, where today we will be discussing oral implantology. Oral implantology is a complex and rapidly evolving specialty that deals with the replacement of missing teeth and supporting oral tissues. The implants need to be inserted into the jawbone in order to support the dental prosthesis. Selection of suitable materials based on their properties, such as biocompatibility and corrosion resistance, is an important factor. Additionally, proper care during and after undergoing this procedure is essential for the successful outcome of the implant placement procedure. To talk more about oral implantology, we have with us today Dr. Nakul Parashurami. Dr. Nakul Parashurami has completed his bachelor's in dental surgery from MGV Dental College, Nashik. He went on to complete his master's in oral and maxillofacial surgery from Rangunwala Dental College, Pune. After his post graduation, he worked as a registrar at Cooper Hospital, working on numerous cases of oral pathologies and trauma. He then established the dental department at Oncolife Hospital, Satara. He has worked in the field of trauma and reconstruction as well as in the field of advanced implantology. Currently, he is attached to various private hospitals across Pune and Satara. He has a special interest in trauma, advanced implantology, and zygomatic implants. He has also presented various papers at various national symposiums. It's a pleasure to have you with us today, Dr. Nakul. We'll start sharing our screen and then you can start your presentation.
All right. Thank you. Thank you for the warm uh, invite. And I would like to thank Doc Plexus for giving me this opportunity. With that, I will start my presentation. So I'm Dr. Nakul Parashurami, and my presentation will be basically divided in next. Can you just go on to the next slide, please? Next slide. Hi, the previous slide, please. Yeah. So my presentation will be basically is divided into two parts. So today the entire the premise for giving this presentation is for our colleagues in the surgical and medical fraternity, so that they can have a brief idea of how implantology is and what kind of procedures we as surgeons do in the oral cavity. So basically, it is divided into two parts. So today's topics I will be covering is of fundamentals of dental implants, and how dental implants can be placed or should not be placed in patients who are diabetic, who are on bisphosphonates and radiation. Also, I will be sharing one of the cases that we routinely do in our dental clinic. The entire reason for giving this presentation is that the basic fundamentals of dental implantology have their origins in orthopedics, and I'll be discussing that in greater detail in the forthcoming slides. So even though it is a out and out dental procedure, the fundamentals remain same as there is a interface with the bone. And next slide. So basically, dental implants are a way of replacing tooth. They are so traditionally there have been few ways in which teeth were replaced. So the first is uh, of removable prostheses, and the second is fixed prostheses. Now, if you look at these pictures, the removable prosthesis is a very cumbersome and a very uh, it is not very comfortable for the patient to wear these kinds of prostheses. If you go on to the fixed prosthesis, you can see it in the photo that the tooth in front and the tooth in back, they both are cut. Once these two teeth are cut to replace one missing teeth, eventually what you're doing is you're destroying two healthy teeth and replacing one missing teeth. And the fixed prosthesis eventually they have their own set of drawbacks that even I'll be discussing in the further slides. So to overcome these kind of these kind of uh, problems associated with removable prostheses and fixed prostheses, there is a third intervention known as dental implants. Next slide. So basically, dental implants are alloplastic and biocompatible materials placed into the bone or onto the jawbone, which is to support a fixed prosthesis or stabilize removable implants, removable prosthesis. Next slide. Now, basically, endosteal and subperiosteal, these are the two types of implants that we usually deal with. Now, endosteal implants, these are fixed directly into the bone, and subperiosteal implants, these were done previously in the 1950s, where they used to cast a framework and then drill it to the bone. But now, with the advent of 3D printing, this has become more sophisticated and more patient friendly, as well as the replication from a 3D printed model to the actual bone is much more easier than a casted framework. So these are the two kinds of implants that we usually place, and the subperiosteal implants or endosteal. So today, basically, I'll be dealing more with the endosteal implants. Next slide. So the implant success rate is differs from position to position along the maxilla and the mandible. In the anterior maxilla, it is around 90 to 95%. In the anterior mandible, it is around 95 to 98. Posterior mandible is 85 to 95, and posterior maxilla is 85 to 90. Now, this is basically, it all depends on the uh, availability of the bone and the nature of bone in these different areas of the jaw. According to that, the success rate of implants depend. More or less, it is more, you can safely assume that the success rate of any given implant procedure is more than 95%. And along with the advent of lot of the implant design and changes in the implant design, as well as the surface coatings, the success rate is definitely on the higher side as compared to the previously done studies. Next slide, please. So, so basically, dental implants have a few very characteristic advantages over the traditional means of replacement of teeth. They are basically bone loss prevention. Now, if you can see this OPG very clearly, you can see that the two implants placed and there is bone surrounding it. Now, this kind of bone, uh, the implant basically keeps on holding to the bone, and you can, as you start moving posteriorly, you can see that there is clear cut drop in the level of bone. This is because there is nothing for the bone to hold on to. This is one of the biggest advantage that the dental implants can provide. uh, it is a natural phenomenon when when there is no part of the body, when there is no supporting tooth structure, bone loss around that part is inevitable. That also happens when you give a set of bridges. Over a period of time, there is a gap created in the stationary bridge and the resorbing bone, and which leads to further food lodgement. All these problems can be averted with the use of dental implants. So the second biggest advantage is it restores the function and the aesthetics of the overall maxillofacial prosthesis. If you look at the second picture, there are three kind of ball attachments on which the denture is supported. Because of the tongue movement, dentures in the mandibular region are prone for movement, and they are little ill-fitting. But because of these additional three implants, the use of dentures becomes very pleasant and comfortable for the patient. If you look at the third OPG in this slide, you can see that there is no proper support on the to the teeth in the posterior side. Now, this kind of, if you give a removable prosthesis in such a kind of teeth, it eventually happens that it is very uncomfortable for the patient because of the additional tongue movement, as well as these cases, as we call as the distal extension cases, it becomes very difficult to give a bridge with a cantilever. So to overcome these, placement of two implants solves the entire problem, and the patient can chew his food properly and comfortably. Uh, Dental implants can also be termed as the strongest and a long lasting treatment option for replacement of missing teeth. Whenever we use dentures, there are these deep flanges and palatal extensions which cause substantial discomfort to the patient. They can be completely avoided once a fully retained prosthesis on dental implants is fabricated. Next slide, please. So, I have chosen this topic specifically for clinicians of other fraternities because the history of dental implant lies uh, in orthopedics. Dr. Brannemark was a Swedish professor of orthopedics who found out that titanium it attaches itself to the bone when it is implanted into it. During one of his experiments, he embedded titanium devices into the rabbit's leg to study bone healing. After a few months, he tried to remove that device, but he could not get it out. Eventually, after a few more after a few more experiments, he found out that it was the titanium was getting attached to the bone, which he termed as osseointegration. And in 1965, he used the first titanium dental implants in human volunteers. So over the next few years, he published a lot of research on the use of titanium dental implants. And in 1978, he started a commercialized product uh, and started selling it under his own brand name. Starting from 1978 onwards, there has been tremendous amount of progress in field of implantology. Earlier, where the the shape was decided to one particular structure, nowadays we have blade shaped implants which have also been tried over a period of time, and now from that the different shapes, it has been uh, to use of CAD CAM and to use of giving teeth immediately after placement of implants. So this has been a huge technological advancement in the past few decades. Next slide, please. So, to get into the basics of how this dental implantology works, we will first have to understand what osseointegration is. So, it is basically a direct structural and functional connection between ordered living bone and the surface of a load carrying implant. Now, if you look at this photo carefully, you will see that in between the threads of this implant, you can see that there is ingrowth of bone. This ingrowth of bone is basically osseointegration. Osseointegration also means that there is no relative movement between the implant and the surrounding bone. Next slide, please. So, briefly, I will explain the physiology of osseointegration. So, once the drilling of the bone is done and the implant is placed, there is infiltration of neutrophils and macrophages in the next 3 to 5 days. It is called as the inflammatory phase. After the inflammatory phase, there are a few release of cytokines and neovascularization that takes place in the proliferative phase. After the proliferative phase, after the neovascularization, there is osteogenesis and formation of bone. So basically, it is so the dental implant, it works along the physiologic process of bone healing, and it creates a kind of barrier. It creates a kind of an interlocking device with the dental implant. So clinically, how do we check for osseointegration? So clinically, implant is basically not mobile when it is tested clinically. The implant is asymptomatic. There is absolutely no infection or any pain associated with it. This crestal levels, the level of level which is at the crest, is is stable, and there is no bone loss associated with it. There is increased mineralization of the new formed bone at the implant surface. The soft tissue is healthy, and absence of peri-implant radiolucency when you take an X-ray are all absent. This shows that the implant has been firmly osseointegrated in the jawbone. Next slide, please. I'll also like to discuss in detail a little bit about the primary and the secondary stability. So, osseointegration basically requires bone opposition on the implant surface without any kind of micro movement. Uh, Once the implant is inserted, the stability of implant achieved is completely mechanical, which is called as the primary stability of the implant. During the healing period, which, as you can see it in the graph, extends up to 6 to 8 weeks. um, there is some biological process of osseointegration takes place, and it becomes a mixture of mechanical and biological stability. It is called as the secondary stability. So further, during the biological process of osseointegration, the surrounding bone physiologically changes during the multiple phases of bone resorption and new bone apposition over the implant surface. Any micro movement of the implant during this phase may lead to the failure of implant osseointegration with the bone. The primary or mechanical stability changes to secondary or biological stability once osseointegration of the implant is completed. So this may take around 6 weeks onwards. So basically, that is to translate it into clinical scenario. We place the dental implant, we achieve a primary stability of more than 25 newtons, and we let the implant heal. So during this healing process, we cover it up with the intraoral gingival tissue and let the implant be as it is. This is That is why the entire treatment procedure of dental implant as a, can be explained to the patient that it is almost 3 to 3.5 months long. Once the process of osseointegration is completed after maybe 3 months, that is when we start making impressions and giving teeth to the patient. uh, Along with the hard tissue integration or osseointegration, the soft tissue integration around the implant superstructure is also very important, and it can be defined as the biologic process that occurs next slide, please. It can be defined as biologic process that occurs during the formation and maturation of the structural relationship between soft tissues and the transmucosal implant superstructures. Now, if you can see here, in the slide, you can see that there is a kind of soft tissue overgrowth along the implant. Now this creates a kind of a seal which is very important, and which doesn't allow any kind of saliva or food particles to go towards the implant surface, which may lead to pathologic changes in the later stages. Thus, for the long term success, there is the careful manipulation and preservation of existing soft tissue is of paramount importance. This is in this is basically checked by the adequate zone of attached gingiva and keratinized soft tissue. Next slide, please. So basically, to give you a brief overview of how a natural tooth and dental implant differ in their interface with the bone, it's there is a beautiful photo. Basically, the most important part that we need to understand is that the implant fuses directly with the bone, and the natural tooth, there is a layer in between which is called as the pedial space. The amount of collagen fiber attachment is extremely high in a natural tooth, but in an implant surface, the collagen fibers cannot directly attach to the implant. So the implant crown is supported uh, onto the implant which is in the bone through an implant abutment, which is a kind of connection uh, between the mechanical structure which is in the bone and mechanical structure which is going to be present into the mouth. Next slide, please. So deal after we have dealt with all these the basic physiology of how dental implants work, I would like to delve in detail about the various kinds of conditions in which the various kind of conditions in which we can place dental implants. Should they be placed or should not be placed? There are various medical conditions, but I would like to um, stress on three basic conditions, which are diabetes, second, use of bisphosphonates. It may be for cancer, or it may be for your osteoporosis, and the third is with radiation. So I'll also like to show you some cases along the way, and tell you about the various clinical implications of placing implants in these medically compromised patients. Next. So the absolute contraindications are recent myocardial infarction, cerebrovascular accident, transplant surgeries, profound immunosuppression. There is severe bleeding issues, active treatment of malignancy, drug abuse, psychiatric illness, and intravenous bisphosphonates. These are the absolute contraindications that are present for dental implants. Uh, so, what do we do in patients who have these? It is always better to have a fallback option, or maybe a less invasive option, such as a bridge. If bridge is not possible, or if the patient is not, it is not possible for the patient to come to the clinic, then giving a removable appliance also works, because uh, doing an implant surgery will not be sufficient. The cost to benefit ratio will be little skewed in such kind of conditions. Next, please. So, a few relative contraindications are a young growing patient. So, as the bone grows, it is not possible for us to place a dental implant, which may lead to problems later on. Thus, an adolescent patient is not a very ideal candidate. So we can wait up to the age of maybe 19 onwards, and then patient can undergo dental treatment. As a severely aging patient, now it depends from aging per se is not a contraindication, but a very frail aging patient, you can maybe give a complete denture. Osteoporosis, the chances of implant failure are again high in such cases. Smoking has been well established uh, to cause. It is well established that smoking causes certain amount of bone level deterioration, which leads to a condition called as peri-implantitis, which is basically bone loss around the implant surface. Smoking also, as we have seen in the previous slides, that it is of optimum importance to give a certain kind of seal of the periodontal tissues, which is not possible when a patient is heavy smoker. Uncontrolled diabetes, I'll be dealing with this in the upcoming slides. Now, positive interleukin 1 genotype has been associated with aggressive periodontitis. It basically, this kind of genotype, it gives an exaggerated inflammatory response to uh, any kind of uh, uh, any kind of injury to the tissue. Thus, this is a can be a relative contraindications when it comes to implant placement. HIV, severe cardiovascular diseases, and Crohn's disease. Now, Crohn's disease has very clear-cut oral manifestations, and placement of dental implants, if possible, can be avoided. Next slide. So I'll be dealing in detail with diabetes and dental implants in little detail. So diabetes, as we have discussed earlier, is not an absolute contraindication for implant insertion. And as various studies and clinical trials have suggested, implant therapy can be successfully done in a patient who is a controlled diabetic patient. Diabetes has its effect on the osseointegration, the soft tissue as well. So basically, what we need to do, what we need to make sure is that there is a minimum 3 weeks of controlled blood sugar levels are there before undertaking the patient for dental implants, and the same kind of blood level should be a controlled blood level should be maintained for at least next 4 to 6 weeks after implant insertion, till the surrounding soft tissue gets healed and osseointegration has achieved. Once the implant gets osseointegrated, increased blood sugar levels may affect the peri-implant tissue, similar to periodontal tissues, as we have seen in uncontrolled diabetic patients. Next slide, please. So, what protocol to follow when a patient with diabetes comes for implant surgery? Adequate screening has to be done. Comprehensive health history has to be done. Has to be taken, and if the patient has gives a history of diabetes, additional information should be gathered about the current treatment regimens that he is undergoing. If the diabetic patient's metabolic control seems to be inadequate, it is best to delay such the treatment for till his blood sugar levels are under better control. The doctor should stress to the patient on the importance of taking all the diabetic medications on the day of surgery and maintaining an acceptable level of metabolic control throughout the healing period. Uh, as in diabetes, it is a sugar rich tissue. A 10-day antibiotic broad spectrum regimen is necessary along with mouthwashes to aid in healing. Next slide, please. So basically, to conclude that uncontrolled diabetes has an absolute contraindication, but we have to if the patient is controlled diabetic, we can safely undergo dental implant procedure. Hyperglycemia has negative influence on the bone formation and remodeling. Soft tissue is also affected by the microvascular complications. So HB1AC figure less than 7 indicates that hypoglycemia levels are appropriate uh, in the preceding 6 to 8 weeks, and giving a thorough antibiotic antibiotic therapy and chlorhexidine mouthwashes can go in a long way in achieving adequate healing in a patient of diabetes. Next slide. So, a patient on bisphosphonates, um, basically, bisphosphonates are a group of drugs used to treat pathologies such as Paget's disease, osteoporosis, multiple myelomas, metastasis associated with breast or prostate cancer. Uh, Bisphosphonates also act on osteoclast, inhibiting their chemotaxis and the lifespan, and hence they inhibit bone resorption and induce osteonecrosis. There is an important difference between bisphosphonates administered intravenously or taken orally. Oral administration of bisphosphonates to postmenopausal women to treat osteoporosis is fairly common. Thus, hence, this group of patients should be investigated for in greater detail. So basically, it was suggested in the 2007 guidelines by the Association of Oral and Maxillofacial Surgery that a 3-year post-treatment time is crucial for the development of bisphosphonate-related osteonecrosis of the jaws. It has been proven that oral bisphosphonates are safer than IV bisphosphonates, and dental implants are safer in patients who are taking oral bisphosphonates for less than 5 years. If the patient is taking drugs for is on bisphosphonates, 3 month pre-implant, and so the drug should be stopped for 3 months before implant placement, and it should not be continued until 3 months after the implant placement surgery. Next slide. Uh, Marx et al. They basically came up. They advised this test called the C-terminal telopeptide test, uh, which is an in it is an in which basically gives you an idea of the inflammatory process in the bones. So this test was suggested by Marx as a predictor for uh, osteoradionecrosis, but it is a controversial test, and it was suggested that values that are more than 150, the implant surgery can be performed with minimum risk and without suspension of the medication. If the values are less than 150, the medication should be stopped for a period of 4 to 6 months. But this is a very controversial topic, and as further research progressed, it was found out that radiographic assessment is more sensitive than biomarkers such as C-terminal telopeptide test, which has to be done on empty stomach. X-rays can be taken at in the clinic as well. So the latest reports do not recommend this kind of testing for BRONJ. Next slide, please. So radiation and dental implants. So basically, radiation. So dental implants in oral cancer patients are successfully used for dental rehabilitation after bony reconstruction of the jaws for retention of a prosthetic device. So that prosthetic device may be a palatal obturator, or it can be a fixed prosthesis for on dental implants. So, various other techniques are used, such as microvascular surgery, where the bone blood supply to the bone has been established, and dental implants are placed. So, with advent of all these things, we need to take into consideration whether to give dental implants in an irradiated patient or no. So basically, radiation, it leads to end arteritis obliterans, that is occlusion of the small arterioles, which eventually leads to osteoradionecrosis. If a patient has already existing dental implants and he happens to undergo radiation therapy, there might be scattering of radiation and it might lead to excessive mucositis, which becomes extremely difficult to manage and painful for the patient. Next slide, please. Now, I'll like to show you this one case which we had performed. So we had given a radiation blocking stent to the patient. Now, if you can see this, the patient has undergone multiple implants. So in the 3 month waiting phase of the dental implants, he was diagnosed with oral cancer. Uh, Once he was diagnosed with oral cancer, he was treated with surgery and was due for his radiation dose. At such a stage, he came to us asking what has to be done regarding the dental implants. Now, the easiest option would have been to remove the dental implants and be 100% sure and safe that osteoradionecrosis will not occur in the post operative phase. But uh, the but it is not a feasible option, as the patient will have to undergo a second set of surgeries to remove these already placed dental implants. So we came up with a device which had basically lead covering on top of it. This lead covering was almost 0.5 millimeter thick, and we created a kind of a stent using this vacuum device. Now, this lead was sandwiched between a soft stent and a hard plastic stent, thus giving so whenever after maybe a month's time, when mucositis starts setting in after 15-20 cycles of radiation, the patient can still find it comfortable to wear such a kind of stent, and the radiation won't have any kind of ill effect or scattering because of dental implants. Next slide, please. So what are the protocols that need to be followed when there is a patient of radiation? So should dental implants be undertaken or no? So dental implants are best carried out more than 21 days before radiotherapy. The total radiation dose should be less than 50 GYs. No implant surgery should be carried out during radiotherapy. No implant surgery should be carried out during the mucositis stage. Now, mucositis stage can last from maybe a few, for at least 5 to 6 months post radiation completion. So, the surgery should be avoided during that period of time. Implant placement should be deferred for at least 2 years after radiotherapy. This is just to be on the safer side and prevent any kind of osteoradionecrosis. So, if the dental implants have been placed earlier, So we can give a temporary prosthesis without any mucosal contact, so that at least the patient can start chewing and start eating normal food. Immediate loading concept should be avoided, and if the surgery is done in such a patient, there has to be a strict asepsis has to be maintained, and a broad spectrum antimicrobial prophylaxis continuing to at least 10 to 12 days after surgery should be done. Next slide, please. So I would like to end this short presentation of today by showing you a case of immediate dental extraction and implant placement. Next slide, please. So if you see this X-ray, you can see two large bulbous rooted tooth which is grossly carious in the first photo. Now, uh, the traditional protocol followed that we should extract such a kind of a tooth, wait for 3 months, then go ahead, place implant, wait for another 3 months, then go ahead and give the patient a prosthesis. But such a kind of a delayed treatment is not mandatory, and it has been shown after through various studies that implant placed in an extraction socket leads to better bone formation around and better osseointegration around the dental implant. So basically, an immediate extraction case, immediate extraction followed by implant placement can be done in a grossly decayed, non-restorable, asymptomatic tooth. There is traumatic tooth loss and minimum bone loss. The tooth to be extracted has no signs of infection such as pain, swelling, tenderness, purulent discharge, etc. The tooth is not periodontally compromised. So all these conditions were satisfied, I extracted the tooth and placed the dental implant. Once the dental implant was placed, I covered it with the mucosa and let it heal for 3 months. And after this, we went on for the prosthetic phase of the implant was started. So with this, I would like to end my presentation and take any questions if you have.
Thank you so much, Dr. Nakul, for that very insightful and informative presentation. We are sure our audiences must have learned a great deal and gained some very useful insights regarding implant placement, especially in medically compromised patients. We do have a couple of questions for you that we'd like to pose before you one by one. So, the first question that we have for you is, which factors promote osseointegration of the dental implant?
So the factors that promote osseointegration, basically they are the local factors. So a good surgery where there is adequate irrigation that has been done, that helps in osseointegration. That the bone around in which the local bone in which the implant is being placed is healthy. So that is one of the the most important thing. The second thing is the design of the implant. With so much of research, various companies have come up with lot of design innovations which lead to better osseointegration. And the third, there are a lot of surface treated implants are available. So it has also been shown through various studies that a rough surface treated implant has better chances of osseointegration than a smooth surface implant. So all these factors basically lead to a better osseointegration.
Right. Thank you so much. The second question that we have for you is, what are some precautions that one needs to take after getting dental implants?
So the basic precautions are, once you have the dental implants placed, and you have completed the prosthetic phase, it basically, see, at the end of the day, the patient needs to understand that it is a mechanical structure that is there in your mouth. You cannot be eating something which is very hard. You cannot be eating something which is maybe trying to eat a sugar cane or break a walnut. So these are very large forces that you're subjecting the mechanical object to. If you do that, it is prone to breakage. That is point number one. Point number two, maintaining adequate hygiene around the dental implants, that is of paramount importance. These two things, if the patient takes care of, the longevity of implants is, we can at least guarantee that.
Right. Right. Thank you. I think the last question that we'd like to take before we wrap this session is, how long does it generally take for dental implants to heal?
So, as we have discussed through through the presentation, it depends basically on two factors. One is in which area the dental implants have been placed, and the second, any other procedure that has been undertaken. So if there is an additional procedure undertaken, so the healing time, it is preferable, like maybe bone grafting or sinus lifting. So maybe from 3 months onwards, maybe 4 to 5 months is what I would like to keep them in the uh, in undisturbed position. And the second thing is that if it is a normal position, even if it is placed in the maxilla, around 3 to 3.5 months is a sufficient time to undertake. If there is an adequate primary stability that has been achieved, you can safely go ahead and do the stage 2 procedures and prosthetic phase.
Right. Thank you so much. I think that will be all for today's session. And to all our audience members, thank you so much for your active and enthusiastic participation in part one of this session. We'll have Dr. Nakul Parashrami speaking to us one more time next week, wherein he'll be talking about more clinical aspects of oral implantology in part two of this session. And we look forward to having you with us next week also. Thank you so
So
much, Dr.
the
Nakul.
Thank you. Thank you to the Doc Plexus team. The next the part of the presentation will be lot of clinical scenarios. Will I like to show how dental implants can be placed even if when there is no adequate bone available. So right from a single tooth in post-traumatic patients or with sinus lifting, and how these kinds of procedures are done to give patient a fixed set of teeth. So that we'll maybe look in greater detail in the next set of presentation. Thank you.
Thank you. Thank you so much. Definitely look forward to that session. Thank you once again to all our audience members. Have a good day ahead.
Good day. Thank you.